All right, just wait for everyone to file in. Give it just a minute here.
I would give them a few minutes to, oh.
Yeah, it seems like we got a lot more coming.
Yeah. Now I need to check if my mouse is on.
Can't see your mouse.
You cannot see my mouse.
No.
Neither can I. You can see my screen though, no?
Yep.
All right.
All right, I think probably have the majority of people in here. Good evening, everyone. My name is Zach Sloan. I'm an advisor with TMFD Financial, and welcome to tonight's presentation on minimally invasive strategies for optimizing peri-implant soft tissue architecture in aesthetic implant dentistry. And I needed a few breaths for that one, but I got it. And our host, our presenter tonight will be Dr. Sherif Sayed. Just to introduce who we are at TMFD Financial, our objective is just to make the financial lives of dentists simpler. And we combine a variety of services under one roof. This includes our tax, investment, insurance, and any other financial planning matters that is related throughout the lifetime of a dentist. We also coordinate with dentists, other professionals. We coordinate with things like lawyers, mortgage brokers, and any sort of bankers, just to make sure that you're getting a truly integrated approach. We found in helping our dental clients that having the convenience of a one-stop financial solution provides them with the comfort of knowing that all aspects of their financial career are synchronized. And when it comes to the financial planning side, when we look at our clients, we make sure that we're taking all aspects into consideration, partly because we have a lot more information at our disposal, seeing the accounting, investments, and insurance all coalesced. So without any further ado, I'll introduce our presenter tonight, Dr. Sherif Sayed. You can take it away.
Thank you, Zach, very much. And thank you all for joining us. And thank you, TMFD, for the invitation. It's really a pleasure to be here with you today. I hope whoever's local got some dinner, whoever's joining from a different area code, I hope you're not too sleepy. And I hope you enjoy this and find it educational. So the topic for today is going to be minimally invasive strategies in optimizing peri-implant soft tissues, particularly in relation to the aesthetic zone. Now, a little brief about myself. I grew up in Cairo, Egypt. My family moved to Montreal when I was younger. And then I ended up doing my dental school back in Egypt. At that point, I went to Boston for my perio residency, ended up considering Boston really as a second home for me. I taught there at Boston University for 5 years, then went on to do a second dental degree at Boston University after my residency. So it really was quite a journey. And throughout this journey, I managed to meet a lot of people that I really can't say have left a small impact on my life. I've met colleagues, faculty, got to meet some of my mentors and teach alongside with them. And then eventually I ended up in Toronto, where I met an incredible group of people. A lot of them are really close friends of mine and colleagues. And at that point, this is where I decided to move back to Canada, to Toronto specifically, so I really like the city. And this is where the journey started. And the second part of the journey started is once I met Dr. Leslie David. We've been in talks for over a year. We have this global dental mentorship that she is heading. And it's really an incredible opportunity for people that are looking to learn about implants, implant surgery. And from practicing with her over the past year, honestly, she's an incredible mentor, and it's been an incredible opportunity. So it's something I encourage you. So I know some people have reached out to ask about possible programs. This is something that I would definitely recommend. Now, without further ado, let's get to our presentation. So we have 5 main components that we're going to be highlighting throughout this process. The first is the challenges that we face as surgeons/dentists in the aesthetic implant dentistry, right? That comes from restorative and surgical aspects. The second is management of the peri-implant or the implant tissue interface between the prosthetic and your soft tissues. And we'll talk a little bit about how we've evolved as surgeons in our surgical approaches, keeping in mind that we don't want to show a lot of blood in this. And then we'll talk about some examples of management of aesthetic cases, which are more or less compromised than your average case that you would get in practice. So when we talk about components of aesthetic implant therapy, we could really split it into 4 main components. Our first critical part is getting the implant in the right spot. I'm sure you all would agree. At that point, we have to focus our attention on developing the soft tissues and the bone around this implant to maintain it long term. And the final part of the puzzle, which is really the important part for the patient, is getting our prosthetic contours and our final aesthetic restoration to blend in with the patient's lips, gums, and teeth. Because when we're looking at aesthetics, besides the facial aesthetics of dentistry, if we were to look at the micro aesthetics, if you will, we're trying to really establish a harmony between the patient's smile, the gingiva, and the teeth. And this harmony comes by establishing a harmonious interface between all 3 transitions. So when we take a look at a patient that walks into our office, now we don't look at a tooth and say it's failing and we're going to place an implant here. This is the obvious. This is what we know. But the discussions that are really important to have with the patient is, what are your teeth going to look like? How does your lip line affect our treatment? What is the final aesthetic outcome that you can expect from a case like this? And you can see a patient like this patient with a very high aesthetic line, very excessive gingival display, severe recession on the central and lateral. And now we have to have a discussion as to what are we going to expect in terms of expectations for the final aesthetic outcome, and what are we going to do? And even if we have to do pink porcelain, this is the discussion that we have to look at and have with the patient before we even start. So finalizing where our transition is going to be, setting up the expectations from the patient, and delivering them as suitable, harmonious restoration is really the goal of our treatment, with obviously the least amount of morbidity if we can. So if we were to look at the 3 main components of why we fail to, or why we have problems with aesthetics and maintenance of implants, particularly in the aesthetic zone, we could really narrow them down to 3 main problems. First is the poor implant positioning, right? Not having the implant in the correct spot. The second part where we focus our attention to is the bone, and having sufficient volume of bone to maintain these implants long term. We also need to focus our attention when it comes to aesthetics on soft tissue management, right? Which is a critical part when we're looking at this harmony that we were discussing between the pink and the white. So our failure to diagnose, plan, and execute, this is what really mainly results us in complications. And if we were to break it down for the purpose of this presentation, the 3 main components that we'll be touching upon is the tooth zone, so the white part, the bone, transition zone, and the soft tissue to the implant restoration interface, which is the tissue zone. So when we talk about the tooth zone, again, it's not enough in this day and age to just say we're taking out the tooth and placing an implant. We have to have an idea of where this implant needs to go in terms of the final restoration, final crown or bridge, if you will. And in order to do that, we need information. We need information about the bone, and we need information about where the teeth are going to go. So when we have a case like this with multiple missing anterior teeth, once we take off this patient's flipper, you really don't have an orientation of where you're going to end up. Yes, you could just say we're going to place 2 to 3 implants for an implant-supported bridge, but we need a little bit more diagnostics before we're able to finalize our plans. So we used to do a lot of analog wax-ups, and these wax-ups, usually the lab, when you send it to them, usually had the tendency to fill in any deficiency or any space. So if you look between the centrals and the laterals and the current ridge, you'll see that you have a space that is left intentionally for the surgeon to highlight where the discrepancies are. Because if we're filling everything with pink, you cannot really relate where the discrepancy is, and subsequently you cannot augment it. Right, so when we do our wax ups, be it digital or analog, it really has to mimic what we want, or what we are expecting as a final restoration, right? And then we take this wax up, again, digital or analog, it's the same concept, and we superimpose it with the bone scan, with the CT scan. And this is where we could really understand where the deficiencies lie. Are they soft tissue deficiencies? Are they bone deficiencies? Or are they a combination type of approach? And then the last part of this, which is technology that's been around for a long time, is that we're actually able to use this information, and we print out sterilizable 3D stereolithographic models to help in patient education, but also help us in terms of the surgery in order to plan and execute. So in this particular case, we decided to use something called allogenic bone blocks, which is basically a block graft that is hydrated in a growth factor to help induce these the integration of these blocks. And you could see the measurements and the accuracy of the replica allows us to not only pre-plan the case theoretically, but we actually go ahead and we can pre-fixate the blocks, we can adapt them, we can mold them to the defect before we even open for the surgical site. So in a case like this, with a severe horizontal deficiency, we're able to minimize the amount of surgery and the time it takes for the patient's surgery. But these guides don't always, or don't only help us when it comes to the final restoration. It helps us in placing our implants, but it also helps us in guiding where our bone graft is going to be. So it's not all done haphazardly. We don't open and place the bone and just let it heal. We now know where the implants are going to go. Then we use these same guides, these same diagnostic tools to translate this information and allow us to place our implants where we want them restoratively and biologically, but also have enough bone to support the implants and maintain them long term. Right? So the first aspect now that we were talking about were the teeth, and now we're going to shift over to the bone, because the reality is in anterior implant therapy, this is what you can expect the bone to look like. It's very thin. You have a very thin buccal plate. I don't know if anyone's had this experience, but when you're taking out a tooth and this buccal plate will either crack or shatter, this is something that's not unexpected when it comes to implants. So it poses a difficulty for us as surgeons to maintain that bone and also augment it without having to put the patients through a lot of surgeries. So the second part of this presentation is going to be focusing on the bone for a while. Now we're going to talk about the implant positioning and the influence of the anatomy on implant positioning, and how do we compromise between the anatomical limitations that we have in the aesthetic zone and the restorative requirements that we need from our final restoration in order to allow us to ultimately reach the successful outcome that we want. So just to understand what limitations we are dealing with, to look at the anterior zone, we're often faced with a very thin buccal plate, more often less than 1 millimeter in 90% of the cases. That means that after we take out this tooth that is present, that is housing the socket, that buccal plate will remodel and will most likely be completely gone, right? The other issue that we face in aesthetic implant therapy is the tooth inclination doesn't necessarily correspond to where we want the implant, right? So this is another problem that we are facing. And from a restorative point and from a surgical point, we found that when implants are placed too far facial, so angled towards that thin buccal plate of bone, not only do you have recession around those, but it makes the restorative part of this procedure a lot more difficult. So ideally, we want the implant in a more palatal position between the cingulum and the incisal edge of that tooth. But that serves us also to allow us room from a surgical standpoint to graft around this area where the arrows are. You can't see my mouse, I'm sorry. But these arrows dictate or allow us more room to place our bone graft material and subsequently maintain the thickness of the bone that we need around our implants. Now, the second part of this equation is the sagittal position of the tooth. Now, Joseph Kahn in 2011 has a very good classification where requires obviously CT scans, and we don't typically approach any anterior case, especially if it's an immediate implant, without a CT scan, but it basically classifies the tooth position in relation to the alveolar housing into four main positions. Class 1, where the tooth is positioned buccally. Class 2, where the tooth is more or less in the middle of the alveolus. Class 3, it's more palatal, and class 4, where the tooth is basically encompassing the entire alveolus, meaning that when you take it out, you're left with basically nothing, right? Or a very compromised site. So for class 1 and 2, it actually works out to our advantage, especially when we're looking at immediate implants, because when the tooth is more buccal, that allows me to place the implant in the ideal position. Actually, in some cases, you're able to even recreate an entire osteotomy. So if you look at these pictures, you'll see that there's the socket, apex of the tooth, completely buccal, and we recreate an osteotomy that is palatal to where the tooth was. That allows us a favorable position for the final restoration. It also allows that implant to be encompassed mainly in the patient's own bone. So it increases our success and increases our stability and increases the biology of these situations. Class 2 is more or less the same, with a little bit less bone available. And then we take a look at the class 3 and 4 sites, and these are where we start facing problems, especially if we're looking at flapless procedures, because most often, or more often than not, you'll find that we run into issues apically, specifically apically in the anterior zone, because you want this implant to be facing out of the palatal or out of the cingulum area, but the bone is not conducive, or the previous socket was not conducive for us to do so, right? And then when we try to do minimally invasive surgery, when it comes to areas like this, and we're trying and went to lectures where they be like palatal screw axis, 100% agreed, but most of the time, or sometimes, you may run into issues like this, where the implant looks good in the mouth, but the patient starts complaining of problems that develop later on because the implant is not in a biological position in relation to the patient's alveolus. Okay, now luckily we have newer technologies, and that's available with most of the implant systems, where that allows us to compromise and angle the implant still within the bone. And even though this implant is facing a little bit more towards the facial or towards the incisal edge, we can still have an angle screw channel or an angle correction and still maintain a screw retained restoration. Okay, so let's have a look now at the type of compromises that we see and how we can manage these cases in a more conservative approach. So we'll focus on the bone, which is really the building block when it comes to implant placement. Bone sets the tone, and that's where we need enough substance to maintain and support our implants long term. Now, the main difference between anterior and posterior sites, and I'm sure some of you do your surgery, and you'll find that in posterior sites, if you're taking out a tooth, all you need to do is place some bone graft material because you have thick bone surrounding these sockets, but you also have a contained environment, right? So all you need to do is really help or encourage the body, or in some cases, you don't even need to do anything. And these sockets will fill in with bone, becomes a very simple procedure. You wait for the healing, you get keratinized tissue. And again, because it's a posterior site, you don't have to worry about the aesthetics, the soft tissue compromise. And you can get a decent and predictable result most of the time, right? And you're going to be able to place your implants without a problem. Now, the problem is in the anterior zone, if you're not able to maintain the volume of the bone at the time of extraction, it most often leads to more invasive procedure to build up the bone. So the basic requirement for anterior implants is to at least have, and this is an important part, at least have 2 millimeters of bone buccal to the implant. Okay, so that's our requirement, 1.8 if you want to be very specific. Some authors have actually recommended 2 to 4 millimeters of bone buccal to the implant, right? And their rationale for it is every time you open, you're losing bone. So they had to always constantly augment the bone in these areas with significant amount of surgery to the patient that no one really likes. We don't like this for our patients. They don't like going through this. And it adds on a lot of morbidity. So it's not invalid. It's just if they want 4 millimeters of bone buccal to the implant, and I want to place at least a 3 millimeter implant, that means I need 7 millimeters of bone in total, right? Tell me where you can find 7 millimeters of bone in the anterior zone. It's not really realistic. So 2 millimeters seems to be our minimum, and it seems to be substantial enough to maintain bone around our implants. Also helps support the soft tissue so we don't have recession over time when it comes to it. Now, the question is, how do we get that bone, right? What is the ideal technique? We have a lot of, in our armamentarium right now, we have a lot of procedures that we could do ridge splitting, block grafts, guided bone regeneration, meshes, metal plates. So you have a really a large armamentarium. Sometimes we use sutures even. But the question is, which one is the best? Which one works better, right? So if we take a look at the literature, and it's funny, they compare a lot of techniques, and you'll find that the results are basically the same for all the techniques. Your range of bone gain is typically between 2 to 6 millimeters, which is sufficient to get you an implant there. Your average bone gain is about 4 to 4.5 millimeters. And your implant survival for block grafts, GBRs, or different procedures is over 96%. So it doesn't really tell you which way is the best way to go. To give you an idea, when we look at vertical augmentation, now the problem is with these complex bone grafting procedures is that you have a very high complication rate. And bone grafting procedures in general, sorry, let me turn this off. So bone grafting procedures in general are quite a highly morbid procedure, meaning that it involves muscle dissection. We have to release these flaps to allow closure. And it causes a lot of soft tissue discrepancies because as we are moving this, I'm going to put this video on even with the sound, but I wanted you guys to get an idea. You see, in order for us to move these downwards, you have to release this tissue, and you subsequently need to distort the soft tissue profile, which in the aesthetic zone is not, especially in patients with a higher lip line, is not our ideal situation. So the main question now that we're trying to answer when it's pertaining to bone augmentation is there or are there any minimally invasive techniques for still augmenting the volume of bone, but preserving the soft tissue architecture? Are there certain techniques that are better than not? Yes, we can understand that flapless techniques are better, but we can't always have flapless procedures, especially when we're deficient to start off with. We don't have that flexibility, right? So we'll go over some cases just to give you an idea of the philosophy or approach of how we would deal with these aesthetic compromise or aesthetically compromised cases in this current standard of practice. So this is Anna, one of my favorite patients. Anna comes into the room. She smiles big at me, and I'm about to walk out of the room, right? She has a very unforgiving lip line, her very high lip line, vertical maxillary excess. She has two failing central incisors, and she also has two canines that are transposed in the position of the laterals because she has congenitally missing laterals. So we're dealing with basically a plethora of problems or circumstances that are not conducive to the best aesthetic result. Take a look at her lip line, we take a look at the biotype, the architecture, and you can see that those two centrals are not doing too well. We then take a look at the CT scan, and you can see that this is a Joseph class 4 relationship, meaning that there's not a lot of bone apical to that socket or even housing that tooth, right? So it puts us in a tight situation where we cannot consider implant therapy to start off with. We first have to augment the bone. Luckily, she was amenable to having a bridge, so that worked out to our advantage. But if we take out these teeth and we don't do anything, or if we take out these teeth and do a lousy attempt to preserve the soft tissue architecture, we then are going to end up with more surgery. So we do something very simple. Starts off with the extraction. Use very minimal force. We try to do flapless procedures whenever we can, especially in the aesthetic zone, especially in someone that is as aesthetically sensitive as she is. Take out the teeth and we place a bone graft material. The only difference is, and the devil is in the details, is where we're placing the bone graft. So we use the bone graft to support not only the bone, not only the socket, but also the soft tissue. So our bone graft is done in something called a dual zone technique, where we're grafting all the way up to the soft tissue. Then we place some collagen membranes on top, and we modify her temporary to capture the soft tissue architecture. So you can see these pontics are now going to fit into the socket, and they're going to provide a prosthetic socket seal, if you will, to seal these sockets. And after 4 months, when we remove these temps, you can see we're able to maintain an illusion of a papilla. Maybe not the same height as where we started off with, but definitely an illusion and maintenance of the architecture with quite minimal surgery. So Anna comes back and she smiles big at me again. And I'm like, okay, I think we're done here. You wanted a bridge? That's perfect. She's like, well, speaking to my friend and she got implants and I think I want implants. I'm like, well, first of all, maybe you need to change your circle of friends. Like, this is not something that is easy to do. Having said that, let's have a look. So we take another CT scan. And we have to really, before we jump into the implant therapy, is once again, visualize how we're going to end with this case. Because right now you could see that you're missing the centrals. The canines are there. The spacing is not favorable. Her gingival margins are not really symmetrical. And it's not like a case where we can mask these discrepancies. So the first thing is we need to look at obviously where the wax up is going to, so this is an intraoral mock-up, but we want to understand where we need to place our implants, especially when we're dealing with two adjacent implants. And the first component of implant positioning is the vertical implant position. Now, this is really dependent on what diameter tooth you're restoring and also what diameter implant you're using. But your general consensus is anywhere between 2 to 4 millimeters from your future gingival margin or the future restorative margin of the tooth that you're restoring, right? 1 to 3 millimeters, 1 millimeter is very superficial for the anterior zone, especially if you're considering an immediate implant, because you have to anticipate that there is a component that is going to go through excessive remodeling or some remodeling. So you'd like to stay between the 3 to 4 millimeter zone. That's usually our sweet spot, especially when it comes to immediate implant placement. Now, this also depends on if you're using a narrow implant to restore a big central, you need to sink this implant a little bit deeper in order to give yourself enough running room to come up with a nice restorative emergence. Now, the second component of vertical implant positioning that is not often discussed is how far palatal your implant is being placed. If you're placing your implant towards the incisal edge, which is personally my preference, and using an angle screw channel, you could have the implant at a relatively decent depth. The problem is, as you go more palatal, you will see that on the right side, I'm sorry you can't see my mouse, but on the right side of the picture, you'll see that this creates a ledge. And if the implant's not deep enough, this ledge is not A, aesthetic, B, hygienic, right? So when it comes to implants that are placed in a more palatal situation, you want to avoid that steep slope that is occurring when the implant's shallow and it's too palatal. And in that case, as the implant becomes more palatal, you have to develop a ratio, if you will, of sinking in the implant deeper to come up with a more harmonious profile, especially a more hygienic profile and natural appearing restoration. All right. The second aspect is, and we know it's a big no-no to place two implants next to each other, but sometimes we have to, right? We can't cantilever. In Anna's case specifically, we couldn't cantilever one implant with the two centrals, especially with the amount of bone that we had. So we have to come up with the spacing and understand what are the components that are going to determine also the papilla, the length of the papilla, the height of the papilla. So the papilla around natural teeth is really having a natural tooth there is really our ideal situation, because this height of the soft tissue papilla is dictated by the supracrestal fibers, the interproximal height of bone on the adjacent tooth. So if your implant is high, low, at the end of the day, what's dictating whether a papilla is there is the tooth next to it. So if I can keep the teeth, and if the teeth next to it are healthy, that's quite critical. The other aspect is very critical when it comes to taking out teeth. We used to just take out the tooth and say, oh, we lost the soft tissue. Before we take out the tooth, especially if we're going to flap the area, you really have to understand and sound the bone interproximally on the adjacent teeth, because that will often dictate whether we can flap the area safely, or if we do flap it, we might end up with an aesthetic compromise that is not easily fixed, if fixed at all, which is loss of the papilla. So that's the first component, right? Is the height of the interproximal bone. The other component is the mesiodistal positioning. And these are based on classical studies. You want the implants to be far apart. At the end of the day, you also don't want them to be very close to each other, right? So when the implants are too close to the tooth or to each other, you lose that support of that interproximal peak of bone. So the spacing between the implants and between implants and the natural teeth is quite critical. And the final part that is important for us to conclude is they found that if you have a tooth next to an implant or two adjacent missing teeth, that you will always have a lower height of the soft tissue, especially in the papillary area, when you're missing adjacent teeth. Meaning that the tooth, keeping a tooth there, and I'll show you in different ways how we can do that, is quite important for maintaining the soft tissue or the interproximal soft tissue papilla, because that's what dictates the height. Now we'll go back to Anna's case and we take a look at this. We've preserved the soft tissue architecture. Now we want to still maintain it, but also deliver to her what she wanted, which is the implants. And this is where really guided surgery often offers a significant advantage. It doesn't mean that it always has to be flapless. It doesn't mean that we can always do it flapless, but it gives us the opportunity to pre-plan the positioning of the teeth and the positioning of the implants and understand the deficiencies that we are facing before we even go there. So we can address them in a more minimalistic fashion. So if you take a look at the X-ray on the left side, you'll see that there's a dehiscence that's going to be expected after placing this implant if we wanted it in the restorative position. Even by angling this implant, this was the threshold for which we can do it. So we go ahead, we plan the case, we understand that there's going to be a deficiency. I typically don't do a soft tissue punch. I like to keep that soft tissue and I use it as a further augmentation to my graft. So we use a small marionette suture, and you could still tuck this tissue on the buccal to further boost the soft tissue. And we'll talk a little bit about this later. But in this case, you can see the bone graft was encapsulated, not really the best tissue to use as a connective tissue graft. We go ahead with our flapless implant placement guided, and you can see even with the guides, you really have to be careful. They're not always as accurate. They're not 100%, nothing is 100% accurate. So you always have to check while you're working, especially if you're doing a flapless procedure in the aesthetic zone. It's not bulletproof, but it's definitely safer than going in brain guided, especially when it's flapless. We then place our implants, adjust the temp, and at that point, we want to preserve that same soft tissue architecture. So we decided, we got good stability of these implants, so we decided that we're going to provisionalize the implants immediately. You can see we adjust the abutments. Again, these are all done now digitally, so you could simply just scan them, put them, send them to the lab or print them in-house, and you deliver the patient the temporary the same day after you've placed the implant. But this was the old school way. To see the implants coming out of the screw axis, you pick them up with, after lining them with some rubber dam, you pick them up with some acrylic or some composite, finish it outside the mouth. And you also have to take care that if your contours, especially the subgingival contours of these restorations, are not ideal, they will end up hurting the aesthetic result. So if these subgingival contours are not concave, where you need the tissue to grow, you will end up pushing the tissue outwards and compromising or collapsing that papilla that we've maintained so long, right? So it's not only the surgery, it's also the prosthetics. Now, we still have to deal with this bone deficiency that we saw on the CT scan. And it doesn't make sense for us to do all that and then at the end of the day, flap the entire area and distort the soft tissue architecture. So the same as we have tunneling procedures for soft tissue, we have tunneling procedures for bones. Actually been around since back where they needed for dentures and a lot of different utilizations. So we take a look at Anna and tell her to smile as big as she can before the anesthetic. And I do a vestibular incision way high up above her lip line, above where she would show it. And you could see that this dehiscence or fenestration defect was almost exactly as where we planned it from the preoperative scan. So we're able to address this with a collagen membrane. Sometimes we don't even use a collagen membrane. We'd use a growth factor combined with the bone, a couple of microsutures. And you can see that's the day where she leaves the practice, where you can see the tip of the suture right underneath her lip. So the incision was completely hidden underneath her lip. Let the implants heal. You'll typically need to wait a little bit longer for these implants to mature because you're also relying on the bone graft to heal. But you could see by provisionalizing and maintaining the soft tissue architecture, see now we've maintained a very nice scallop of this tissue that we could further refine. Now, it's not logical for me to talk to you about aesthetics where we're delivering the result as such, because you could still see the canines are significantly bulky. The premolars are shorter. The symmetry of the soft tissue is still not there. So that's where the mock-up and especially the intraoral mock-ups help the patient visualize the final result and make them understand where we're trying to reach, but also makes us understand what we're trying to achieve. And then again, instead of doing our conventional crown lengthening procedures, we do a flapless crown lengthening procedure when it comes to aesthetics and certain indications, where we basically do our gingivectomies based on where the final margins of the restorations are going to be. We reflect the soft tissue gently, we access the bone, I'll show you a video of this, and utilizing piezo surgery, we're able to go in at certain depths to allow our bone removal in a very minimalistic fashion, right? So we're able to do our ostectomy without injuring the soft tissue by utilizing this. And you can see this is the day that the patient leaves from the surgery as such, right? So it's quite minimally invasive. What we found on these cases is that surprisingly, you get a lot less rebound of the soft tissues because provided that you've had enough bone removal, because you're not mobilizing the tissues as much. So we're able to go straight finals to finals earlier, because the soft tissue takes less time to mature. And we're also causing a lot less disturbance and mobility of the soft tissues in the healing phase. And this is where the case was finalized. And this is, I believe, a 2 to 3 year follow-up of the case, so holding up quite nicely. These are the CT scans with the bone grafts in the area, the implants, and yes, the 2 years post-op of a very happy, smiley patient. I believe we have a question. Zach, Jake?
Yes, we have one question.
Yes, that's a very, Dr. Amr, it's a very good question. In this case, it was splinted. Ideally now, I wouldn't do the same.
Just to read it out, I don't believe everyone else can see the question. So the question was, did you leave the provisional splinted or did you section it afterwards?
Yes, so to answer the question, I'm just trying to find my mouse, 1 second. To answer this question, in this case, it was splinted. Now we do not, we would splint both implants, but we would not splint them to the rest. And the final restoration was not splinted. That answers the question. Okay. Now, our last piece of the puzzle is the tissue zone. And the tissue zone is really a critical component, obviously, of our final result. Now, could expand a little bit about the tissue, maybe you could do it another time, but in essence, what I'd like to see around our implants, I'd rather have thin bone and thick tissue rather than thick bone and thin tissue. And I'll give you a very clinically applicable example. If any of you have seen a CT scan of an implant, a long-standing implant that clinically looks fantastic, there's no issue at all, but you take a CT scan and incidentally you look at that implant and you find that this implant has no bone buccal to it. If the tissue was thin, you will probably have a lot of recession around this implant. Whereas if the tissue is thick, then this implant, even though the bone over time will shrink away, you still have maintenance and protection over that implant long term. So soft tissue grafting and soft tissue augmentation is quite critical both for anterior and posterior implants, but obviously more critical when it comes to anterior implant therapy. And this has been substantiated in studies over the past decade or so, where we've had thin peri-implant tissue implants showed increased bone loss, increased incidence of recession, more tissue discoloration, and less tissue masking when it comes to areas with thicker tissue. And the advantage of soft tissue is that you could really do it at any time. You could do it at the time of extraction of the tooth. You could do it at the time of the implant placement. And if all fails, you still have that last time at the time of uncovering. And I know patients shy away from it. Even dentists, to be honest with you, will shy away from referring for soft tissue grafts because most of what patients hear about are conventional free gingival grafts, how painful they are, how uncomfortable they are, poor aesthetics, all that stuff. And a lot of our referrals also have that same issue because they don't want to put their patients through all this hassle, and completely agree. But the reality is we have really changed how we do our soft tissue grafting, especially around implants. So take a look at this, for example, where we have a case like this, the implant's placed in good bone. There is definitely good bone around it, but the deficiency is surprisingly coming from the soft tissue. And this is how we would typically do a soft tissue harvest now. So it's not like your free gingival graft where we would take a big area from the roof of the mouth, we leave it exposed, it's extremely raw, it's extremely tender for the patients. We take this with a single incision 9 out of 10 times. See, we're able to get enough tissue. Closure is really not an issue. The healing is very different. And then when it comes to the implant or the peri-implant surgery itself, we use a combination of tunneling instruments, microsurgical blades, a lot of armamentarium that has been developed over the past decade or so to allow us to do these procedures in a more minimalistic fashion. So you can see we create a tunnel, a pouch around this implant or buckle to the implant. And with a couple of sutures, you're able to introduce this graft, oftentimes even fold it if you need to. So you'll see we're folding this graft in two to really thicken up the soft tissue. And then we introduce this graft into the site to further augment and thicken the tissue that allows us to maintain this long term, right? So we're looking at this, and this is your entire procedure. See 1 or 2 sutures to keep everything in place. The recovery is obviously different than how a conventional free gingival graft is done. The follow-ups are a lot different, patient satisfaction is a lot different, and the results are obviously a lot more enhanced because you have more blood supply to your wounds. Let's take a question before.
Yeah, we got a question in the chat box here. In cases where provisionals are not splinted, what's the success rate of osseointegration for single immediate implant surgery combined with immediate provisional crown?
So I'm not, so quite high. The answer is quite high. I am not too familiar with the current, I'm just sorry, let me close this because I lose my mouse every time. I'm not too familiar with the most recent literature, but I will tell you it's in the high 90s. Definitely. So provided that the criteria are fulfilled, meaning adequate implant stability, all the requirements for osseointegration, regardless of the splinting. Like the splinting, I think in this case was done, but we don't typically do this, and I'll show you other cases. Actually, this case is about this. It's not something that favorable bite, no excessive load on the implants as they are in the healing phase. Implant provisionals are completely out of any excursive movements and out of occlusion, and adequate stability, usually above 35 to 45. But yes, with the new implant technology designs and how we construct, and the temporary obviously has to be stable. It typically isn't a problem. I hope this answers the question. So to go actually to that point is immediate provisionals. And this is useful in some cases where the patient's aesthetics are quite demanding. The patient has an occupation that they don't want to wear something removable. You can't get them something removable, but it also helps with the final aesthetic architecture when it comes to sensitive areas. So take a look at this. We have a failing 2-1, and 2-2 is actually an implant in temporaries with a very compromised papilla in that area. You can see the 2-1 has recession that's been masked by the temporary contours. So this is how we would typically approach a case. I'm not a big fan of always provisionalizing, but if the patient really wants to and it's a favorable condition, then yes. If we're pushing the boundaries, at that point, I would say no. I'd be safer and I would explain it to the patient, and most of the time they are okay with it. But we still do them on certain patients, and actually some dentists recommend or prefer them. So when it comes to the tooth extraction, again, it has to be atraumatic. You cannot have a traumatic flap extraction socket, especially when you're looking to do an immediate implant, especially when you're also close to an implant or adjacent to an implant, which is in the 2-2 site. Now, in this case, we had it planned the same way as the first case I showed you. The only difference is I open the flap or I reflect the area earlier on so that I can anticipate, I know where the defect is going to be, and I can anticipate it, but it makes it cleaner for us to reflect and to also visualize the defect instead of waiting for the drill and the implant to go through the tissue and go from there. This is a straight implant. Most of the time we use a tapered implant just for any questions, and then you can see the implant's position. And at that point, if we leave it just with the bone graft, it is going to be quite difficult for us to correct later on. So if we don't preserve what we have or try to further augment it at the time of, we'll probably end up losing more than gaining. And when it's a more sensitive case where you have an implant that's already integrated and deficient, you don't want to go for another surgery in this area. So we're going to augment both the soft and hard tissues at the same time. So we take a connective tissue graft from the roof of the mouth. We stabilize it around the buccal aspect of the implant, but we also are going to hide it underneath the distal papilla of the 2-1 site to boost that soft tissue, to give you that volume for the papilla that will support it after the tooth is being taken out. We then localize our defect. We can introduce our membrane, and you can see it's a lot easier to now visualize once we've had this. And then we continue on with our grafting procedures. Again, we still typically would graft all the way to the soft tissue area. We use resorbable sutures now in the mucosal areas just to avoid any irritation to the patient. And then this is a case where we are provisionalizing the implant the same day. And you could see this is the final soft tissue architecture. And although not an ideal result, but you could see definitely, considering you started off with a situation that is not ideal, I think for us and the patient, he was quite happy with the final result, especially when we have two adjacent implants next to each other. Now, the last case I wanted to show you is a very, very sweet young lady. She came in, she had a failing 1-1 upper right central incisor, if anyone's out of our system, and deficient soft tissues, high lip line, very young girl. She was in college at the time. It was really heartbreaking. And she had a crown lengthening, a functional crown lengthening around these areas to get the crowns on top. So we're dealing with quite a compromised situation as is. And unfortunately, the upper right central had to go. So we approached this in the same way as we did in the case before, where we would take out the tooth atraumatically, place our implant. You could see this crown was retrofitted to accommodate for her new implant. So it was an immediate provisional. We take a connective tissue graft to augment both the buccal contours and the interproximal soft tissues in that area. And you can see the soft tissue secured in place underneath that papilla to support it, and the temporary retrofitted to have to be completely out of occlusion as well. Now, following the healing of this, we were lucky in her case that the teeth were more squarish. And we then use a combination of some minor crown lengthening. And you can see this is with an electrocautery. See, this is the implant following the 5 to 6 months of healing. You can see the soft tissue profile here. And at that point, we're basically adjusting the temporary contours, and we'll talk a little bit about the temporary contours, to allow us to maintain the soft tissue thickness around the implant, which, as we discussed, is quite critical, but also maintain the height or create the gingival zenith that we want. So the conventional way of doing this, once again, was we marked where the zenith is, where the gingival margin is, okay? And this is called the critical contour. So the area where we want the soft tissue to land or rest is called the critical contour, and that will be convex. And then anything underneath the soft tissue, we want to have concave. So subgingival is the subcritical contour, and you want that to be as narrow as possible because this is where the soft tissue volume is going to occupy. But anything that is convex is going to push the tissue out of the way. So in her case, we wanted to increase the height of the central slightly. So we add a little bit of composite where we want the tissue to migrate apically. And anything underneath of that, we will under contour, make concave. And you'll see what this has as an effect. This is a different case, but just to give you an idea, is you could almost see where the tissue thickness is being maximized right around where you want it, around that implant prosthetic interface. This is a barrier for your soft tissue. It's a protection for the implants, a protection for the bone underneath. And if you over contour your restorations or your temporaries, you lose the thickness of that tissue. And that's where we start seeing recessions. Now, it's not only enough to contour the temporaries, and again, these are all older workflows. We do them very differently now. But basically, you use these temporaries and you create a custom impression coping. You could do it with digital technology. You could do it in the conventional way where we would use the temporary, because if you take out this temporary and put your impression post in and take an impression, that tissue would have altered by the time you get everything together. So what we do is we used to take this impression coping out and we would create a mold, and in that mold, we will literally inject flowable composite and screw it back into the implant. So as the lab starts to fabricate their soft tissue margin, or soft tissue profiles, they are mimicking the contour of the temporary, which is what you want for your final restoration. So in this case as well, we did a similar approach where we did a minor cosmetic crown lengthening. And I just wanted to show you one piece over here. You already saw the procedure. But with this technique, you could almost see where the bone is. You could see the bone over here. And it's a very thin plate of bone, but you could easily remove and make sure that everything is visualized and maintain the soft tissue architecture. And this is where her case has ended up in comparison to where she started with her teeth, right? So we used a combination of the temporaries, the soft tissue grafting, the bone grafting, and the prosthetic contours to deliver her to that final result. Now, if we're talking about preservation, and this will be our last point of the day, if we're talking about preservation, there's really no more superior option. And I don't want to rush over this technique. At the same time, this presentation is not about partial extraction therapy. So I just wanted to give you an idea of what's available now that has been substantiated with science. Maybe not as long-term, but well over 10 year mark now. And you could see that these cases are really the pinnacle of preservation of both soft and hard tissue, which is partial extraction therapy. And that involves us intentionally leaving a shield, so it's more commonly known as socket shield, a shield on the buccal aspect attached to that buccal plate. So we do not completely extract the tooth. We extract only a portion of the tooth. And we remove all the root canal remnants, we remove any apical remnants of that tooth, and we leave just a buccal shell. And what that buccal shell will do is going to trick the buccal plate. It's going to maintain these attachments and the ligament, the blood supply for that buccal plate, and subsequently maintain the volume and the architecture of the tissue overlying it. Right, so just to give you an idea what's possible, but this is a whole different topic. So this is a failing for left central. You can see the severe resorption. Now you could also see at the CT scan cuts that this tooth is projecting out of the buccal aspect of the alveolus, right? So once I take out this tooth, I'll be left with a fenestration there. Again, we do a very similar concept in terms of how we approach this case. The only difference is we're leaving that shield, and I'll show you a video of that. So we go in through the root canal space as if you're preparing for a post, if you will. Go in even sometimes with gates glidden to be able to remove all the remnants and get a tract. And you go all the way up to the apex of the tooth, and you section that tooth mesiodistally, removing the palatal portion. Then you would round off that shield, and you could see the implant is now being placed palatal to that socket shield, right? So the osteotomy is completely driven away from the shield. You don't want to put any pressure on it, not with the implant, not at the time of extraction, and definitely not with the final prosthetic. So if we follow all these guidelines, you'll see that the prosthetic contours are also under contoured, anything subgingivally, in order not to compress the shield in that area. And you can see this is a case done, that was a 7-year follow-up. That's the last time I saw her. I'm sure I'll see her again, but you could see the preservation of that soft tissue. And this was also with an immediate loading approach or immediate provisional. It's a non-functional load. And you can see the soft tissue maintained, but if you look at it from an occlusal standpoint, this is really where the socket shield procedure is you can't compete with it, provided you have the right indication. So no significant pathology, no significant fractures of the root, teeth are periodontally healthy, the tooth fragment is not loose, you're able to remove all the fragments. But again, we could talk about this at a later time. There are strict criteria, and in some criteria, it's actually a lot less invasive than if you were to remove the tooth completely, let's say an ankylosed anterior tooth. Anyone who's removed an ankylosed tooth knows that it's a lot more traumatic to actually remove the tooth to the bone and to the site, right? So sometimes this technique, and this is where I most of the time leave it for, is to avoid the trauma that comes with these ankylosed teeth. Or in a case like this, where you could see the radiologist managed to find an accessory, so an anatomical variation. That anatomical variation of the blood vessel is not really my concern. My concern is after I take out this tooth, I'll be left with no bone and compromised sites both on the palatal and buccal aspect. So in order to attempt that, to preserve that buccal aspect, especially in a case like this where the patient has an adjacent implant, this is how we would do the procedure. We go ahead, we do some of those cases guided now. So we have a small pilot guide that will direct us exactly into the root canal of the tooth. Then we go ahead and we section this fragment. If we're unable to get it completely, we go after it with a round burr or a round diamond. They have specific kits for this now. And you can see we're really shaving this shield to dimensions that are not going to prevent the implant placement. They're not going to impede on the implant ideal position, and allow us to remove any remnants of that tooth that may cause a further contamination. Then we place our implant in a guided approach, and this guide was actually with a marker to allow us to seat the implant exactly where I want it, right? Not always the easiest to do, but when done right, this is without any editing of the video. This is our first attempt to place the temporary. This is a lab fabricated temporary done by ProArt Lab, I believe. And you could see not a bad situation for an initial trial. So some minor adjustments to the contact, some minor adjustments to the occlusion. And you can see this is the immediate post-delivery of the temporary. And this is our last follow. He lives in somewhere else right now, so he should be coming in for a follow-up soon. But you can see this was at the time where he was finalizing his case. And you could see the soft tissue around this implant and the so to reach our end, and I'll take the two questions that we have on there in a second. For our conclusions, aesthetic implant relies on the success of both or a combination of a restorative and surgical synergy, right? It doesn't come with one or the other. What we're trying to do is we're trying to maximize our patients' comfort, service, and soft tissue architecture, especially when it comes to the aesthetic area. At the time of extracting the tooth, so ideally we'd like to keep the bone preserved. We'd like to maintain as much of the soft tissue or the tissues around the teeth at the time of extraction, if not even boost them, in order to allow us to avoid more complex procedures later on. So that's really the premise of how we would like to practice. And it turns out that then the aesthetic zone, that if we have the adequate planning, we have a lot of technology advantages now that allow us to be more precise in our treatment. That provides us with the edge that we need to deliver our patients the result that we want, that they want, with the least amount of morbidity and least amount of surgery. Okay, I thank you all for your attention. It was really a pleasure being with you. it's the end of the day. I'm sure some of you are tired. I'm going to have a look at the questions. Oh, thank you, Dr. Arlen. So Dr. Arlen, I need to put a nice comment about this. Okay, so I don't think we have any questions.
We have
Dr.
a few
Arlen, I'd
questions
like
coming
to
in
thank
here.
you for that gracious invitation. Dr. Murray Arlen is one of the, I've met Dr. Arlen a few years ago. I've had the pleasure of meeting him. It's always been a mentor, and we've come a full circle, even though he's in Florida right now, enjoying the nice weather. But I appreciate you watching and being around and sticking around. And thank you for the invitation. Dr. Amr, thank you so much. What kind of bone is your pref? So as far as the questions, Jake, do I have to read them out?
That'd be great.
So what kind of bone is your preference for these cases where you anticipate fenestration / days? So just to give you an idea, I use exclusively or 99% of the time allograft bone. I have a preference to use the cortical bone. Cortical bone for me gives me the best of both worlds. It doesn't resorb as fast. It typically resorbs the ones that I use. I go in 5 months. It's rock solid. It provides me that space maintenance. So it acts as a xenograft, if you will, in the sense that it doesn't wear away as fast. So it doesn't turn over as fast. I use a mineralized bone. I don't use any demineralized bone. I may use putties in sinus lifts. But for most cases, I would use a mineralized. You could use a mix of cortical cancellous mix, or you could use a cortical bone. That's what I preferably use. I don't use xenografts. I've shied away from xenografts for 2 reasons. I find that the xenograft will tend to linger around in the tissue, and obviously we know it's going to linger around in the bone. But the xenograft will tend to exfoliate over time, especially if you don't have a membrane covering it. So when I showed you that dual zone technique where you would place the bone graft above the level of the bone, most of the time you'll see exfoliation of this bone graft material if you're using a xenograft. Okay, so that's something that I've tended to avoid. I avoid them in sinuses. I know Leslie, Dr. David still uses them in sinus grafts. I just typically don't use them anymore. I haven't found a reason to, and I find that they turn over a lot less. They're harder when you drill into it, but that doesn't mean they're vital. The lab provisional that were, the lab provisional that was used, we use 2 main labs. I use ADL lab, ADL dental. It's by Spiros, and I forgot the other partner. They're now heading the lab. Fantastic results. And I use Pro Art Lab. And I believe that provisional was Pro Art Lab. Either way, they're both the same. And I've also used Roshan Dental, who gave me a very nice provisional. So the labs themselves are actually delivering very high quality lab fabrications. I'll tell you that unless you're using an implant system that is conducive to you doing this, sometimes you'll need to torque in the implant a little bit deeper, a little bit shallower, and you can't get it to fit exactly right. So if you follow the protocol, and if you have faith in the lab that you're working with your workflow, it typically is not a problem. Will you need to make some adjustments? Most likely, yes, right? There'll always be that small deviation. Dr. Arlen, thank you for your question. So comparing a CTG placed at the time of an immediate extraction versus a healed site, do you think that there may be a compromise to the blood supply of the thin plate with immediate extraction timing? So 100% agreed. And it's actually interesting that you mentioned that, because there's another part of the presentation that I took out and to talk about exactly that. Now, what Dr. Arlen is referring to, and correct me if I'm wrong, is when you reflect the periosteum over that thin buccal plate, you will tend to have resorption of that buccal plate, right? So 100% true. The bone doesn't compensate for it. So in cases where the tissues are thick, I will typically not do a bone graft, a soft tissue graft. In cases where the tissues are thin and the buccal plate is thin, if I do not do the soft tissue graft, I will probably end up with more compromise of that side. So what I do, when I do the soft tissue graft, I do it, let's say I lose 0.5 millimeter in terms of buccal, or 1 millimeter of buccolingual width, I'm augmenting 2. So I'm ending up in a net profit, if you will, when it comes to the augmentation of the tissue. So yes, there's definitely a win-loss ratio in here, but definitely the soft tissue will help boost the thickness and the profile of the tissue, especially in thin phenotype cases. Thank you. You're too kind. You're too kind. Thank you, Dr. Arlen.
It seems as though that's is the last question. If anyone has any last questions they want to ask, you can enter them now. Okay.
I
Seems
think
as
we have
though,
a hand raised. Do we have a hand raised, or is it just?
a couple hand raises. Let's see. People, a few more seconds. All right, well, it seems as though it's, as you mentioned, time for everyone to enjoy their night.
Enjoy
like to
night,
thank,
enjoy dinner. I'm gonna go have dinner myself too. Thank you everyone for your attendance. If you have any questions or if you need anything, don't hesitate to reach out anytime. Thank you all.
Thank you, Dr. Syed.
Thank
You
you.
can join us March 22nd with another webinar with TMFD Financial. This topic is on life insurance with a member of our team, Sanjeev Tidkey. So thank you all for joining us, and hope you all have a great night.
Thank you.
Thanks, everyone.
Thank you.
Thank
Have a good night. Bye-bye.